So I think we will start. Good morning, good afternoon, good evening. A very warm welcome to this session. I'm very happy to see you here, to have this interest, specifically in this exciting topic, technological innovations to support health systems and related research. I just want to be sure that the slides are also on the platform. Can I just hear from the co-host whether they're there? Yes. Okay, great. In particular, I would like to welcome our speakers for this session, and I will introduce them each when they come to speak. My name is Inke Mattauer. I'm a senior health financing specialist working at the World Health Organization in Geneva, and it's my big pleasure to actually moderate this session here. Before we start, let's have a few tips on using the platform. In particular, there will be translation in English and in Spanish, and on the right-hand side of the platform, you will see this translation box. I should say specifically that one presentation is in Spanish, so you may just already look a little bit into that. You can choose between Spanish and English. Also importantly, there is a live support chat function on the right-hand side on the top. It's this little red box on the right-hand side. So if you need any help, maybe on the translation function, just contact the colleagues. And very importantly, we will have a Q&A and discussion section after the presentations. And so throughout this session, please provide your questions, your comments. And when we come to that part of the session, we'll go back to your questions and comments there. And last but not least, just to say that this session is recorded. So let me now outline what this session is about. Now, as it's put in the conference program, the rapid emergence of new digital technology, artificial intelligence, and big data brings new opportunities to strengthen health systems and to combat the growing burden of complex chronic disease and health inequity. But of course, there are also challenges. And so in this session, we want to discuss these new potentials with illustrations from various countries and various examples of digital innovations. I'm sure we will also hear from the participants. And then we also want to explore the challenges. Maybe one word on the terminology. While different terms are being used by the presenters, can we just go back again? What we ultimately are looking at are electronics, so to say, digitalized tools, systems, platforms, devices that generate, that store, process, analyze, organize, or transmit data for the ultimate purpose of contributing to better health. I think this is really what brings us all together here. Now, we have 5 presentations. They were selected and allocated to this session, and I think they greatly complement each other. The first 2 presentations are somewhat more conceptual overview presentations, and this will be followed by 3 presentations that focus specifically on a tool in a specific country. And then we go into a Q&A session. But before we go into the presentations, we have a poll. And so let me just shift back to the other screen. We would like to get your view. We actually first want to get a sense of where participants are from. So the first question is just about which region you are from or are you working on. We're using the WHO regions here, so the 6 WHO regions. If you can just hold there and give 15 votes so far. Okay, I don't yet see the results coming in. Okay, no, I don't see the results coming in, but let's go to the actual 2 questions. We would like to know, in your view, what is the largest benefit of digital innovations to health systems? We have 4 answering options. Obviously, these are not comprehensive, but let's take those 4 as a starting point for the discussion. Here, I do see some of the answers coming in. I'll just wait a few more seconds. So if you can please vote. Okay, it's still moving, so I'll wait a bit more. Please give in your view. Okay, yeah, that's very interesting. So basically we see that majority of participants think that the primary benefit are efficiency gains and cost savings, followed by increased accountability and transparency. And some few participants voted for the two other options. Okay, that's very interesting. I think that gives us already sort of some idea of where we see this. Now, the second question is, in your view, what is the biggest challenge or risk with respect to digital innovations that need to be considered and addressed? And again, we have 4 answering options, which are certainly not exhaustive, but they are some of the challenges. Okay, that's very interesting. So this is sort of more or less equally distributed, more or less a fourth to each. Technical and regulatory capacity gaps and increase in digital divide and exclusion of certain population groups are a little bit higher. Yes, okay, it's still moving. But yeah, very interesting. I mean, I had no clue of your views and where you stand, but yeah, interesting. So technical and regulatory capacity gaps got most of the votes there. All right, let's keep that in mind, and we may come back to this in the discussion. So let's now move to our speakers. And our first speaker is Emily Connahan. She is a monitoring, evaluation, and learning manager. Emily has worked in global public health for more than 10 years at the intersection of data science, health systems, and digital health. And in her role at PATH, she collaborates with project teams to design and implement measurement and learning approaches to accelerate impact. Emily has expertise in mixed methods, in complex evaluations, and data-driven action. Prior to PATH, she was a fellow at the Institute of Health Metrics and Evaluation at the University of Washington. Now, Emily will give us an overview of the wide range of tools, digital tools that we're actually concerned here with. So now let's listen to her presentation. Over, thank you.
Hi, my name is Emily Connahan, and I lead the Monitoring, Evaluation, and Learning portfolio for Digital Square at PATH, an international NGO. Digital Square is a PATH-led initiative funded by the U.S. Agency for International Development, the Bill and Melinda Gates Foundation, and a consortium of other donors. Digital Square works to connect health leaders with the resources necessary to support digital transformation. Digitalization of health systems has been an important component of health system strengthening in many countries. As health systems integrate digital tools, the data produced by these systems can provide new insights to accelerate program improvements. However, countries need to integrate data science approaches to make full use of the data available to them. The work I'm sharing today was funded by the Rockefeller Foundation to explore whether the same type of model implemented by Digital Square to increase alignment, coordination, and scale of digital health tools and approaches could also apply to data science tools and approaches. In this context, data science refers to the intentional and integrated use of data to produce actionable insights that strengthen health systems. The challenge we are seeing is a slow adoption of data science in public health systems, particularly in low and middle income countries. This challenge is due to many barriers, including fragmented investments and lack of coordination, which stems in part from limited evidence and awareness of which data science investments lead to impact, a lack of globally accepted criteria for evaluating data science assets, and there's a risk of continued fragmentation as data science is applied within health verticals and not systematically. We also see inequitable distribution of data science skills, expertise, and capacity worldwide, and a lack of visibility into the data science tools that are available to countries. There's currently no place for stakeholders to convene to learn about existing data science assets or how to efficiently integrate them into country health systems. A stronger link needs to be made between data science assets and the needs of decision makers working within low resource health systems. This is where a health data science exchange comes in. This would be a virtual space, a curated platform to bring together stakeholders, tools, and approaches, and build a community to support the uptake of data science in low resource health systems. As part of this work, we convened a diverse advisory group of public health professionals, technologists, investors, government officials, and implementers to advise on what a health data science exchange could look like. We identified the need to increase the visibility and availability of both demand and supply side resources. On the demand side, resources would increase understanding of user needs and could include, for example, a problem stack that helps identify shared health system challenges that could be addressed with data science solutions, translation resources to help stakeholders understand what data science assets have worked in other contexts and the value they bring, and operational guidance, which can help to lower the technical barrier of entry to implementing data science approaches. Supply-side resources would increase the overall visibility into the availability and quality of data science assets and architectures. For example, an asset catalog would be a comprehensive list of what data science assets, meaning tools or approaches, are available. To illustrate the type of information that would be included in a health data science exchange, we conducted a landscape review of use cases where data science approaches have been applied in low resource settings to strengthen health systems. Our advisory group prioritized these 3 use cases to demonstrate the value of data science approaches. First, the Visualize No Malaria project, which strengthened data analytics tools and capacity to support malaria elimination in southern province Zambia. Second, the pilot implementation of a data-driven decision support tool developed by ThinkMD to improve community-based diagnosis and treatment of child health in Nigeria. And third, the introduction of information and communication technology tools built on Damagi's ComCare platform to support frontline workers to improve maternal and child health in Bihar, India. For each use case, we identified the data science assets that were included. The bulleted list under each use case provides an indication of the type of data science assets that could be extracted from these use cases and included in a health data science exchange. Finally, we also developed a classification schema to organize the assets so they can be easily found by the exchange users. There are 2 levels of classification: high-level categories represented by the row and column headers, and detailed subcategories represented by the bulleted examples. At a high level, assets are organized by the phases of the data science cycle that they support across the top of this table. There are data capture assets that focus on the phase from defining and conceptualizing data through to capturing or collecting that data. These include assets related to data design, data capture, and data validation. Then in the second column, there are data transformation assets that focus on the phase once you have data captured and need to transform the data into insights. These include assets related to data aggregation, data processing, data analysis, and data exploration. And the last phase are data impact assets that focus on turning those data insights into real-world impact. So this includes assets related to data dissemination, data use, and data communication. The rows across the left further categorize assets at a high level as one of what we refer to as the 5 Ps that reflect the type of asset. So there are products, the tools, systems, or software that enable users to collect, report, and analyze data. There are policies, the guidance and documentation that govern and enable data production and use. Processes, the management structure and practices surrounding data generation and use. People, the workforce that supports health data utilization and service delivery at all levels, including assets to strengthen workforce capacity for data science. And finally, proof, the body of evidence or evidentiary standards used to demonstrate the value of a data science application. And then there's the more detailed level for those stakeholders who are using data science approaches day in and day out that might find a more detailed classification useful to further find and categorize assets. So the bulleted lists in this table illustrate the types of subcategories that could be considered to provide more granularity. Finally, I want to close by thanking the Rockefeller Foundation that made this work possible, the Digital Square staff who led the work, and the advisory group members who contributed their perspectives and expertise. Through this work, we have identified the need for a health data science exchange. We have begun to map out what this could look like in practice, and the advisory group has made recommendations to establish the exchange and continue to research the impact and scalability of data science assets. The full publication and details of the Health Data Science Exchange can be accessed through the Digital Square website listed here. Thank you.
Thank you so much, Emily, for this really interesting presentation, making the point that data science assets are really needed to support the intentional use of data through digital technologies with the aim of strengthening health systems. And the idea of a health data science exchange and how to organize that is extremely interesting, and we should hopefully come back to this in the discussion. So now I'm coming to the next speaker, which is actually me. I was actually asked whether I would also chair this session, even though I'm a speaker. It's a bit unusual, but the good thing is, since the presentations are pre-recorded, I don't have to monitor time and I don't have to stop myself. So that's a good thing. Anyway, here is my bio. I don't really have to read that out, just to say that I'm leading the global work on strategic purchasing for UHC at WHO. And I have a strong interest in work on digital technologies for health financing, which is what the presentation is about. So now we can have the recording. Good afternoon. Thank you very much for your interest in this topic. My name is Inke Mattauer. I'm working for the World Health Organization in Geneva. In this presentation, I would like to share some initial reflections on the potentials and the risks of digital technologies for health financing and the issues that may need to be considered. So what are we talking about? In a nutshell, digital technologies encompass all electronic systems, devices, and tools that generate, store, process, or transmit data. With respect to health financing, we can immediately think of a health information management systems, and its digitalization helps improve planning, policy making, and implementation, etc. But there's of course much more. Digital technologies range from internet and mobile phone use, including web platform functions and mobile phone applications, to the use of digitalized payment. Also, big data analytics is on the rise, together with the use of algorithms, machine learning, and artificial intelligence. These digital technologies change the way business is done, and they change how the health financing functions are undertaken. That is, they alter the way the various stakeholders interact with each other. So here's my key argument. Whether digital technologies for health financing are being used or not, the widely agreed upon health financing principles that guide reforms in support of universal health coverage remain valid. The principles don't change, of course. For example, there's the principle of relying predominantly on public or compulsory funding sources. Another key principle is to enhance pooling and to reduce out-of-pocket expenditure, etc. Hence, the potentials and the risks of digital technologies need to be assessed in relation to the UHC objectives, the immediate ones listed here, as well as the final UHC goals, that is equity in access, fair financing, and quality health services. At the same time, digital technologies must also be evaluated in relation to other broader key principles that are not specific to health financing, but also highly relevant to it. These include data privacy and confidentiality, as well as data accuracy and data comprehensiveness. This is extremely important to ensure that the outcome of algorithm decisions are equitable. Here are some examples of the potentials of digital technologies, although So this is not comprehensive. With respect to revenue raising, we see that mobile phone applications are on the rise. So for example, they can simplify the payment of health insurance contributions or help remind members to re-enroll. In general, such apps help reduce administrative costs for both individuals as well as the agencies. They can also enhance the inclusion of population groups that previously had difficulties to make such payments, let's say from a logistical point of view. Digitalization and digital tools, making various information management systems interoperable across different ministries or different agencies, can improve the process of identifying and targeting eligible beneficiaries for a health coverage program. An example on pooling: when various information management systems are made interoperable through the digital tools across separate coverage schemes for different population groups, the data analysis can then be integrated and aggregated. And this can facilitate other health financing reforms. For example, it can improve facilitate pool merging, or it can improve the risk equalization mechanism, or it can help harmonize benefits, payment methods, and payment rates across different schemes. Many digital technology examples relate to purchasing. And so let's think of mobile phone-based or web-based platforms of coverage schemes. These improve information provision on benefits, on cost sharing, on the services available. They can also provide much easier access to reporting or grievance mechanisms, often anonymous. And the last example, digitalized claims analysis together with artificial intelligence can facilitate fraud detection, and coupled with big data analytics, it can reveal the service priorities of providers as well as patients. And so to sum up, digital technologies for health financing can contribute to UHC goals. They can enhance transparency, they can strengthen trust, save time, reduce administrative costs for both individuals as well as agencies, and increase efficiency. However, it is equally critical to be aware of the risks or the challenges coming along with these digital technologies and of how and for what they're being used. I'm sharing a few reflections, but again, this is not exhaustive. We see that mobile phone payment apps make it easier to collect contributions, also from people in the informal economy, As private voluntary health insurance schemes make use of such apps, it can easily increase voluntary financing and thus possibly decrease the overall share of public finance. And that is not in line with one of the key health financing principles. A serious implementation challenge relates to uncoordinated digitalization of information management systems across different health programs or different health financing schemes. And this can further institutionalize already existing data gaps on vulnerable population groups that have no explicit coverage. And when algorithm-based analytics comes in, these data gaps can lead to biased algorithm outcomes that exacerbate inequities. Another concern is about claims analysis when coupled with big data analytics. This can enable the spotting or even the prediction of high risk or high cost individuals who may potentially lose their health coverage because they're driven out, or who may have to pay higher contribution rates. And that is not in line with the UHC objective of their financing. Finally, there are regulatory and capacity gaps. So there may be no regulation or ineffective or insufficient regulation. These gaps relate to data protection and data security issues. It really relates ultimately to the question, who owns the data and who has access to the data. There may also be gaps with respect to the algorithm design and monitoring processes, but that's of extreme importance to ensure that the impact of algorithm decisions are in line with UHC goals. And so in sum, there are various equity and ethical challenges, and policymakers who want to progress towards universal health coverage need to find answers to these. So what can governments and the global community do to reap benefits and minimize the risks of digital technologies for health financing? At the start, it's critical that digital technologies for health financing are also considered that they're part of a national digital health strategy. The opportunities need to be explored, and if beneficial, they they should be supported to promote progress towards universal health coverage. But at the same time, their risks must be much better understood and dealt with. As a first big step, there's need to build up the technical capacities in digital technologies for health financing and to strengthen the regulatory capacities to address the legal and the ethical challenges. And there are many actions needed. I can't go into them here, but just to say that certainly the global community also has a role or could support this strengthening of regulatory capacities. Last but not least, and actually I think it's a first step, governments and the global community, as well as the research community, need to have much better evidence on how digital technologies affect health financing and UHC in practice. And I think there's a big research agenda awaiting us. With that, I thank you very much. I'll look forward to your questions and to your feedback on these reflections so as to move forward on this discussion. And I'm happy to further exchange with you. Thank you very much. Okay, so we have that second presentation. Maybe just to say that obviously this was a focus on health financing, but the approach and the argument could also be applied to any other part of health systems. Okay, so let's move on to our third speaker, that is Clara Abu Samra. She is an instructor of public health practice and an evidence lead at the American University of Beirut. Clara has extensive experience in the field of health system strengthening, health policy, policy making and quality improvement. Clara has supported several ministries, UN agencies and NGOs locally as well as internationally in developing and advancing evidence-informed health and social policies into impact. Clara will present and discuss a particular digital tool, namely a health data platform. So let's have her presentation.
Hi everyone, my name is Clara Abu Samra. I am an instructor of public health practice and an evidence specialist at Knowledge Policy Center. Today I'm going to be discussing the Health System Eye, an innovative approach developed by the K2P Center to make evidence-informed decision-making. So given the Sustainable Development Goals era, there's a really need for radical changes in order to achieve the different Sustainable Development Goals. And in addition, policymakers and stakeholders are pressed by time and have limited access to research evidence and real-time data to make effective health system decisions and even social system decisions. So here comes the need for open data and data innovation in health and social systems. The lack of that can be detrimental for the health of the population, especially when it comes to priority setting decisions, resource allocation, and health equity. Specifically when it comes to situations of crisis, and now we're talking about refugees, displacement, the COVID-19 pandemics, all of which really rely on data and evidence to make informed decision-making. So here comes the idea when it comes to open data and the need for data. The K2P Center has done needs assessment survey to identify the best modalities to visualize and disseminate timely data and information. And the Syrian refugee crisis was used as a priority topic, given that we have more than 1.5 million refugees in Lebanon, to develop the different modalities. So we conducted a scoping search of data innovation. Researched some of the data modalities, data visualization modalities that can be used, identified a sample of 60 participants, some of which are policymakers, others are researchers, developed and piloted the survey for the policymakers and researchers, developed the data visualization modalities. We contacted then the participants, did the data collection, did the data analysis, and came up with the results. So just to identify that the different data modalities that were used were infographics, animation, and reportage as data visualization. And we also had the text to support and to see which one is most used or even needed by the policymakers and researchers. So the results came as following. Less than half of the researchers and policymakers were satisfied with the way health data and evidence is communicated to them. Researchers and policymakers believe that data visualization can help them in making evidence-informed decisions and recommendations. text and infographics was the best combination modality to inform decision and to access the timely data and information. And most importantly, participants reported the inconsistent, non-systematic, fragmented, invalid, unreliable, not up-to-date, and incomplete data in Lebanon. And this is a main issue when it comes to making evidence-informed decision-making. So currently the situation as such, you have different organizations, they have their own data sets, they are not sharing it with anyone. It is not accessible by stakeholders and policymakers, and they are unable to make informed decisions. So the need is as following. The need is to have more of a platform that brings together all the kinds of data in an open data platform that would support policymakers in accessing this kind of data to make informed decisions. So given that, K2P Center came up with the idea to make a health system eye platform, which is an open data platform to support policymakers and stakeholders and even researchers in accessing data. So there were 4 different modalities for this platform. One on interactive data, where you can access manipulated data, come up with different graphs. Research study section, which allows accessing research studies, most up-to-date studies on a specific topic. News articles, whereby a priority topic can be identified based on the press tracing that is conducted by K2P, whereby all open newspaper articles that are found online are extracted on this topic. And then products and infographics that are developed by K2P are integrated into the 4th section. Just to note that for the piloting of this platform, K2P used the topic of cancer and used the data from the registry of the Ministry of Public Health to identify the data on cancer in Lebanon. So this is an example of the interactive data that can be manipulated and changed using the Health System Eye platform. As you may notice, you have the incidence, you have the age, and then the variable of cancer type, where you can add or remove this, manipulate through it, whereby the graph can change to identify if there has been an increase in a certain age or a decrease in a certain age. So based on the developed platform, the Health System Eye platform, there has been an evaluation of the platform. The evaluation came as such. The majority of respondents were satisfied with the look and feel of this platform and the user friendliness of the platform. 50% of the respondents identified the most important element of this platform is the data visual section, which is the interactive data. The most preferred feature of the platform was the interactive data, the timely efficiency, ability to bring data to the hands of stakeholders, and adaptability with a wide range of audience. And finally, there was a high need to scale up to different topics, given the important utilization of this platform. So given that we were able to utilize this platform using the cancer data to identify that cancer is a priority, given that there has been an increase in cancer incidence throughout the years. Therefore, we developed a knowledge translation product, which is a briefing note, which followed a systematic process to the development of this knowledge translation tool, utilizing a specific search strategy to develop it, identifying key systematic reviews to identify options to overcome the problem of cancer in Lebanon. And this was used and tailored through the COVID-19 pandemic to develop a rapid response to protect people with cancer during the COVID-19 pandemic, given that cancer is a high priority when it comes to COVID-19. And this was also translated to Portuguese in order to be able to access and to inform more stakeholders throughout the globe on this specific topic. And it really informed the decisions on protecting people with cancer during the COVID-19 pandemic. So just to wrap up, the need for accessible, credible, and user-friendly data and visuals is increasing throughout the world, especially when it comes to health and social crises, and such as the refugee crisis and pandemic. And finally, this innovative platform is really needed to scale up to the Eastern Mediterranean region and beyond different topics, also to inform decision-making. This has come to an end. Thank you so much for listening to my presentation.
Thank you so much, Clara, for this really interesting presentation. think this was a very good illustration of the use and the usefulness of a health data platform for providing information to policymakers and other stakeholders for improved evidence-based decision-making. The next presentation is in Spanish. So for those who would want translation, maybe you just go into that feature on the platform. So our next speaker is Lisbeth Acuña Merchan. She is the executive director of the Colombian High Cost Disease Fund. And at that fund, Lisbeth leads the work on healthcare models, on risk adjustment approaches and mechanisms for ex-post management, incentives, and results and outcome generation. She is also in charge of leading research projects in high-cost diseases as input for health decision-making. Moreover, she is the General Director of the International Network for Prevention and Chronic Kidney Disease. So let's have her presentation. Thank you.
Mi nombre es Lisbeth Acuña, soy la directora del Fondo Colombiano de Enfermedades de Alto Costo y quiero hoy hablarles sobre la innovación para la equidad y la calidad de la atención en personas con estas enfermedades en el sistema de salud a partir de un sistema de información que hemos creado para que se disminuyan las brechas en los procesos de atención de las personas con estas enfermedades. Colombia tiene un sistema de salud basado en el aseguramiento y nosotros como Fondo Colombiano de Enfermedades de Alto Costo cumplimos un papel que es poder llegar a construir una metodología basada en evidencia y poder aplicar unas metodologías definidas por el Ministerio para poder ajustar la unidad de pago por capitación, pero también evaluar en el sistema de salud a través del monitoreo y la información con los datos a partir del reporte de las entidades, el acceso efectivo al sistema de salud en estas enfermedades de alto costo. ¿Cómo lo hacemos? A partir de los datos que vienen de las personas con estas enfermedades, de los procesos de atención y poder combinar estos datos para que se optimice su flujo con herramientas tecnológicas, un gobierno de datos, un sistema de información fácil, ágil, interoperable que pueda permitir el almacenamiento de estos datos para explorarlos a partir del Big Data y construir una información que nos permita poder tener a disposición de todos los actores del sistema la información para poder tomar mejores decisiones. En este momento contamos con más de 28 cohortes compuestas por 5.663.854 personas seguidas uno a uno, nominalmente identificadas, que son las que consumen la mayor parte de nuestros recursos en el sistema de salud. Y esta plataforma que hemos diseñado tiene una arquitectura con un enfoque integrador de datos en donde la calidad, el análisis, la interpretación y la incorporación de tecnologías exponenciales y su gobierno de datos son los pilares para poder competir con todas las entidades en su gestión, en su mecanismo y su procesamiento de datos para que estas entidades puedan basarse en resultados y tengan una competencia basada en resultados a partir de un flujo de datos fácil, un intercambio de información que tiene unos estándares de interoperabilidad establecidos por el gobierno nacional. Las fases de este desarrollo incluyen la combinación de forma innovadora de conectar a las instituciones, un gran Big Data que ayuda a encontrar nuevas opciones a partir de los datos acumulados y una tercera fase que es poder integrar e incorporar el blockchain para la seguridad de los datos. A partir de estas fases hemos construido una forma diferente de optimizar los procesos de atención y que esta información esté no solamente disponible para el paciente, los aseguradores, los prestadores del gobierno, sino para cualquier ciudadano que pueda identificar cómo están los procesos de atención en estas enfermedades. Es decir, pasamos de la recolección de datos a la transformación, de la observación a la automatización de procesos, de la descripción a la predicción y de la publicación a la visualización para poder democratizar la información. Y con base en esta plataforma que hemos diseñado, construimos un programa interesante de formación y entrenamiento para poder promover dentro de las entidades la cultura data driver, que es la que nos permite llevar en el ADN estratégico de cada una de estas instituciones la data para tomar mejores decisiones. No solamente es tener datos, sino poder analizarlos, comprenderlos y subirlos a un nivel estratégico para que las entidades, a través de esa cultura y esta promoción de la cultura data driver, puedan llegar a tener unas decisiones basadas en datos y no en opiniones. ¿Qué nos hemos propuesto? Que esta información pueda contribuir a mejorar los procesos de atención en hemofilia, cáncer, enfermedad renal, en VIH, en artritis reumatoide, en hepatitis C, y que todo sea basado en las oportunidades de la atención, poder disminuir los tiempos de espera en cáncer, poder lograr la indetectabilidad en VIH, lograr una detección temprana de la enfermedad en artritis reumatoide y una remisión de la enfermedad y la cura en hepatitis C. Y que esta información nos pueda permitir orientar a las entidades a una competencia sana, pero basada en resultados, y poder promover el pago por resultados, que en este momento lo estamos aplicando en 4 de las enfermedades de alto costo que ha definido el país. Poner a disposición de todas las entidades herramientas y soluciones tecnológicas para la toma de decisiones, democratizando la información a partir de estas herramientas que pueden consultarlas en la página web con un acceso gratuito, y que nos permita difundir el conocimiento en diferentes escenarios, en diferentes espacios nacionales e internacionales, para poder fortalecer no solamente los procesos de atención, sino también la construcción de guías de práctica clínica basadas en evidencia local, protocolos de atención y demás partes que hacen de la involucración o el involucramiento de los pacientes en la toma de decisiones para estos procesos óptimos. Es combinar los datos, la tecnología y las personas, y eso es lo que promovemos a partir del diseño de esta plataforma, y que nos pueda permitir dar respuesta en este momento, como lo hemos hecho para la atención del COVID, siendo Colombia el único país en la región que puede tener el detalle de cada uno de los pacientes y rastrearlos porque tienen mayor complicación para COVID-19. Esto nos permitió poder elaborar herramientas y soluciones tecnológicas para atender la pandemia, y que los gobiernos pudieran ser mucho más efectivos a la hora de focalizarlos. Y finalmente, pues no olvidar que esto nos ha llevado a que podamos redefinir roles, a poder involucrar la tecnología en la toma de decisiones en salud, pero de una manera mucho más inmediata, usar y apropiarlas, esas tecnologías que ahora más que nunca es relevante, pero que el mejor ahorro es el conocimiento aplicado. Por eso no se puede desligar los datos de las personas y la tecnología. Y que esta tecnología nos permita no solamente conectar a las instituciones para tomar mejores decisiones, sino tener una mayor y una fortaleza en la conectividad humana. Entonces, con esta plataforma y SISCAC, que es nuestro sistema de información, se puede llegar a lograr mejores datos, mejor información, mejores decisiones, mejores resultados, una mejor experiencia para el paciente, pero sobre todo una mayor equidad, y contribuimos de esta forma a la sostenibilidad y a una justicia social. Muchas gracias.
Thank you so much, Lisbeth, for this really interesting presentation. And I think what we really need to appreciate here, and I would like to emphasize, is that you have managed to create this interconnectivity in this information management system to provide information and knowledge across the different stakeholders, the insurers, the providers, the government, in real time. And what I also find interesting is that it contains will contain elements as it's being further developed, of big data, of predictive analysis, and blockchain, as you mentioned. So maybe we can go a little bit deeper into this in the discussion. Thanks. So now we, last but not least, we come to our final speaker. This is Anibal Kois. He is a biostatistician at the Health Systems Trust in South Africa. Anibal is active in the field of health system strengthening, research, and strategic support in the health programs implementation. He is a senior lecturer at the School of Public Health and Family Medicines at the University of Cape Town, and also has a consulting position at the Burden of Disease Research Unit at the South African Medical Research Council. Anibal will share with us how to use artificial intelligence to analyze health research trends in South Africa. So let's have his presentation.
Hi, everyone. I'm Anibal Kois from Health System Trust, HST, an organization active in South Africa since 1992, supporting governmental effort for the improvement of the public health system. The work I'm presenting today is the result of a collaboration between HST and the South African National Department of Health. This work is about assessing the level of alignment between health research conducted in a country and the actual needs of the population. Research is essential for improving population health and progress towards the Sustainable Development Goal. And in an era of research-constrained health system, government needs to play their role to encourage and support research efforts around topics that are under-researched compared to the population needs. This is crucial in low and middle income countries like South Africa, where research are especially scarce. But how do we actually assess the existence of misalignment between population needs and health research? Well, it's quite evident that the first step is to have some way of measuring both. But in this presentation, we only focus on the second task, that is measuring health research trends and characteristics. And we take for granted that measuring burden of disease provide a fairly adequate picture of the population health needs. The most obvious way of tracking research is looking to published output, such as journal articles and formal reports. These documents are usually of good quality, accessible electronically, and presented in a structured form. But they only give an extremely limited picture of the actual situation on the ground. Many of you will remember the 2009 Lancet article by Chalmers and Glasgow. We highlighted how most health research is never published, and when so is published with years of delay. But what else is available? The idea underlying our work is to access information from a repository of study protocol, that is to intercept research interest when they are generated, not at the end of the process. Protocols for health research are commonly subject to some form of scrutiny, and the most evident example are ethic review committee, but this is not the only example. In South Africa, all health research conducted in public health facility, for example, must be pre-authorized by provincial health research committee that are established by law. The process is managed electronically by the National Health Research Database, the NHRC, which include record of all research planned in public facility. While not all health research require access to public health facility, this represents in South Africa the large majority. The NHRD, therefore, is an interesting, timely source of information for our objective. This data source, unfortunately, consists mostly of structured information buried within the protocol in free text format. To access this info, we develop an automatic classifier to categorize the protocol according to the Health Research Classification System, HSRC, a well-known system used internationally for the management of research grants. The classifier imports a protocol abstract from the database and produce the most likely classification of each study in terms of one or more of the 21 health category over the HSRC. This process is realized in two steps. In the first step, the classifier interfaces electronically with the medical text indexer of the US National Library of Medicine to associate the protocol with a set of mesh terms. In the second step, a machine learning algorithm, currently trained on a set of 14,000 protocols manually classified, uses the set of mesh code to assign each protocol to relevant health categories. More in detail, the procedure uses a model averaging approach where 4 different classifiers are used to independently estimate the probability of a given protocol to belong to a category. The final probability is calculated as a weighted average of the 4 predictions, with weight represented by the accuracy of each classifier. The distribution of the various studies is then calculated by averaging the predicted probability. A post-adjustment is also introduced to take into account the imperfect accuracy of the algorithm and adjust the well-known Rogan-Gladden formula in the slide. We tested the accuracy of the system in recovering the actual distribution of studies from a set of artificial data set with known distribution across category. The results are quite encouraging, as summarized in the figure, where the 45-degree blue lines represent the truth and the red points represent the prediction made by the classifier. We use the system to estimate the distribution of the about 9,500 protocols submitted to the NHRD in South Africa between 2015 and 2019, and to quantify the alignment with the burden of disease from the GBD study. For the comparison, we mapped the GBD category with the HSRC category using a procedure previously used by Chinneris and colleague, which is described in the additional material that accompany this presentation. The most evident result we want to comment is that the relative excess of research on infectious disease and the relative deficit of research in the field of injuries of accident, in both cases about 10%. Both results are quite reasonable in the South African context, given the concentration of research effort and funding in the past year associated with the AIDS-TB epidemic, the first in relative resex now, and the large incident of injuries accident partly related to violence. In the second feature, we see the temporal trend of the same indicator. Even here, for the sake of time, I'm just giving a simple comment to show that both in the case of the infectious disease and injury accident, the misalignment seems to be decreasing over time, which is a good thing. Finally, like all other studies, this study has limitations, many limitations. We highlight two. The first is that the NHRD doesn't represent the full extent of research in the country, but this limitation must be weighted considering that other sources, such published output, are also largely incomplete and much less timely. The second limitation, the system quantifies the current research in terms of number of studies, implicitly putting in the same category a small student-led study with a multi-million-dollar clinical trial. Weighting protocol by study budget might give a close representation of the reality, and we are working now on this. This approach is allowed by our system, but the problem is to access information currently not always present in the NHRD. In conclusion, we think that the example application just described very briefly show how relatively simple AI technique can be applied to assess and consolidate large amount of information only available in free text and structured format, and provide policymaker and administrator timely information for monitoring health research trends against the national priority. Thank you for your attention.
Thank you so much, Elris, for this really fascinating presentation and illustration of how artificial intelligence can be used and help policymakers get a better overview of whatever is going on, in your case, current research trends. And I also appreciate the fact that you have actually outlined how the algorithm was developed, was tested, was evaluated to give us sort of some rough understanding of how this actually can work. So thanks so much for that. So we have heard about very different examples of digital technologies being used in place, and the speakers outlined the benefits of these tools. Ultimately, I think we can say that they all aim at improving the functioning of health systems, for example, through improved efficiency or better evidence being made available. We also heard a bit, though maybe less, about the challenges. But I think this is all great food for thought. And I think now it's time to go into the discussions to hear from you, your questions. We're interested in your views. So in fact, let me just go over to the chat functions. We have a couple of questions there already, some of them of clarifying nature. So let me actually take up the first one. Why is interoperability such a challenge in the health industry? And I would maybe ask Emily or Clara to respond to that. Lisbeth, maybe you can also bring that in. So who wants to start?
I would be happy to start with this question. Thank you, Enke. So I think this is a very important question when it comes to the health system. And as you may know, the health system is very complex. And you've got many stakeholders working in the health system. You've got NGOs, you've got the public health sector, you've got the private sector, all of which work on different services, different capacities, different processes. And this really pushes into the priorities that they have and the objectives where they want to end up working in or achieving later on. And as you may know, there are many funders in this field. Each of us have also different priorities. And sometimes this sets a stage for the type of data that we're collecting. And unfortunately, there is no standardized way of collecting data, all of which are collecting information on a different aspect or on a different stage. And there comes the issue with interoperability, because we're not working in the same system, we're not working on the same programs, we're not working on the same priorities and objectives. But the question comes at stage where how can we actually leverage on those differences to come to a standard one point where we can actually work together to push for evidence-informed decision-making and to push for better decisions using those platforms and using this kind of data. Thank you.
Thanks so much, Clara. Very interesting points. Emily, would you want to add?
Yeah, thanks, Enke. I would just agree with everything Clara said. And I think it is really important to just keep in mind the complexity of the number of actors and the amount of data that is being captured, and completely agree that it really starts from having some shared standards and defining what those are. But one other point I would add is that I think as a field, as a sector, we also need to get a bit better about articulating the benefits of interoperability and kind of conveying what is the return on investment for interoperability. Because, as Clara said, there are a lot of funders in this space who have their own set of priorities, and that's really their focus. So how do we kind of create scalable, sustainable emphasis on building out that interoperability aspect and really articulating what the impact and the potential benefits of that can be.
Thank you, Emily, for that. Lisbeth? No. Okay. Maybe I can add one or two points on that. I must admit, I don't know what the interoperability issues are in other sectors, but there are certainly huge, the problems of interoperability are certainly huge in health. And it's not just technical or IT related issues. I mean, they can be solved with the respective skills and capacity, but I think there are also governance issues. You need to have a governance of your health information management systems and setting up standards that are harmonized, where everybody agrees to, and that can then be enforced to all the, enforced in quotation mark, to all the different stakeholders, purchasers, providers, etc. So I think at the end of the day, this is also a bit of a power game, and there is need for very strong governance in that area. Okay, then I'm moving on to the next question. There was, one question. How can payment via mobile phones increase voluntary financing? Is there any reason behind that? Yes, thanks for that question. Maybe I just can expand. I think this refers to the presentation I made. So what we observe, although without any specific, hard data, is that mobile phone payment options and apps are often used by voluntary health insurance programs. So what we often refer to as private health insurance. And these mobile phone apps make it then very easy to make your contribution of whatever 200 shilling or whatever the contribution is. And so that can increase easily voluntary financing, because it's the voluntary health insurance schemes that primarily or seem to more often use these and apply and offer those tools. And so as voluntary financing increases, relatively speaking, the public finance the share of public finance might go down. So this is certainly something to observe and to actually evaluate. One person asked whether these sessions will be recorded. Yes, they are. So just to say that in between, they will be available. Then we had a question on, what was it? There was a question on whether publications are available on this subject. That may have referred to the presentation on health financing, but actually I would like to actually share that question with all of us, because I think this is probably an issue that you have also encountered. So who wants to come in? You know, what's sort of the level of publication with respect to digital technologies? Where do we find the evidence of how they work? You know, what their benefits are? What's your experience?
If I can, I think it's a good example how we the problem related to big data, because I think there are lots of publication. The problem is that orient yourself in this sea of publication and to find the right evidence. But there are lots of studies going on regarding regarding general applicability. But now I think we are going in the phase that we are trying to do more realistic experiments. So to try to see if this application can work in real context, not just within a trial. We know all conditions are perfect, the people are selected, but can we work in South Africa in a rural area? And I think there is lots of evidence. There are, yeah, I would say yes. You can look, you will find.
Okay, thank you, Annabelle. Anybody of the other speakers wanting to comment on that question?
I can just add, as we were kind of conceptualizing this idea of a health data science exchange that my presentation was about, you know, we were looking for use cases of where different data science approaches have been applied, particularly in low resource settings, and how they have led to health system performance improvements or ideally health impact. And I will say there is, we found a gap in the evidence, particularly around some of the more frontier technologies that I think people think about when they hear data science, so more in the AI and machine learning space. There's a lot of promising technology out there. And, you know, as Annabelle said, there's a lot of studies that show how some of these new technologies can work under ideal settings. But we found kind of a dearth of evidence in how they've actually been applied in practice in health systems in low resource settings. So I think I see that as an evidence gap and kind of a research agenda to continue to build out is, you know, how are some of these really promising technologies actually being operationalized and leading through to health impact, and really making that connection all the way through to health impact, I think is very challenging to measure, and something that we need to continue to build the evidence based on what works.
Great, thanks, Emily. Maybe I can also reflect from the health financing perspective. I think the question was, where's the published evidence on impact of digital technologies on health financing? And in fact, there's very, very little published. Basically, when we started this work, you know, there are maybe 2 or 3 specific articles on that. There's a lot, of course, on digital health, on digital tools for health services, but there's very little on health financing. It seems to me that most focus is actually on health insurance schemes of, you know, how to collect contributions, you know, reminders for enrollment. There isn't really much published, but you would find maybe, you know, web page announcements or web page, you know, blogs. And so that's where I really see a need, and I think there is a research agenda waiting there, because first of all, there is need to actually develop a framework in order to help us evaluate and assess the benefits, but also the risks of digital technologies for health financing. So I think the health financing areas may be a little bit sort of lagging behind. There's much more on the other areas of service delivery or clinical care. Okay. Any experience of use of artificial intelligence in the health sector? Maybe this is for, maybe I can hand over to Anibal. So the question is, any experience of the use of artificial intelligence in the health sector, not diagnostics and publications? Your mic.
Sorry, I was asking you to repeat, but I wasn't speaking. As Emily was saying, when I was speaking, I was referring mostly to application of technology or mobile technology and for clinical use that are more common. But regarding specific application of artificial intelligence, I completely agree with Emily that the evidence is scarce. So as far as I know, there are application in terms exactly in terms of classification, in terms of identify the private sector high-risk patient. In South Africa, there are some private health provider that use artificial intelligence system to exactly what you say, to identify high-risk patient and positively to help them to reduce the risk. Let's not see the negative aspect to push them out of the scheme. But for as far as I know, the application are more in this sector than directly regarding, for example, governance or more general management of the health system.
Thank you.
My experience.
Okay, thank you, Anibal. Lisbeth, are you going to respond in English or in Espanol? I don't hear you.
Spanish, please.
In Spanish. Okay. La pregunta, bueno, voy a la pregunta, ¿puedes hablar del uso de la inteligencia artificial, quizá en tu sistema de información? Maybe muy breve para que te podamos...
Claro que sí.
Gracias.
Bueno, el sistema de información que se obtiene o se tiene a partir de los reportes que vienen de los aseguradores y los prestadores de la atención de las enfermedades de alto costo, tiene incorporado tecnologías exponenciales como es el Machine Learning, inteligencia artificial, para poder hacer la verificación de toda la información antes de su análisis e interpretación. ¿Por qué? Porque tenemos que hacer una verificación previa de validación de lo que se reporta y se hace a través de las historias clínicas de cada paciente. Una cosa es lo que se reporta y otra cosa es lo que se observa y se valida contra la historia clínica y exámenes clínicos de los pacientes, y se ha optimizado para poder hacer mucho más procesamiento de volumen de datos a partir de esta tecnología, involucrando estas herramientas que nos permiten no solamente identificar la data estructurada y no estructurada y poderla convertir en un análisis mucho más robusto, pero sobre todo veraz. En los sistemas de salud hay muchas fuentes de información, pero las fuentes de información probablemente a veces no son confiables. ¿Por qué? Porque no se hace un proceso importante de validación. Entonces nos llenamos de un gran volumen de datos, pero con poca calidad. Y cuando se van a utilizar para poder generar evidencia que aporte a las políticas públicas, es poco confiable. Nosotros nos basamos a veces en las estimaciones que tenemos de otros países, en los referentes internacionales, pero ¿qué pasa? nuestra población es diferente, el contexto latinoamericano y en nuestra región es diferente al comportamiento del contexto de la población de Europa, de Asia, de África, etc. Entonces, aquí es importante tener en cuenta esas cosas, que una cosa es la estimación, otra cosa es la observación, que las estimaciones nos sirven para ver brechas, pero que ojalá nunca pudiéramos llegar a alcanzar los datos estimados cuando podemos hacer intervención de políticas públicas con datos de nuestros locales, nuestra localidad y de nuestros pacientes atendidos en el sistema de salud. Gracias.
Okay, great. Thanks so much again, Lisbeth, for this very comprehensive response. The question was really, how is artificial intelligence being used in the Colombian health information system of this high cost disease fund? And maybe you may have followed the translation, so I will just try to translate in one sentence, more or less, if I can, for those who haven't followed the translation. So basically, she was saying that for this interconnective information management system, there's a high volume of data, and it's so much data that actually there's need for data structuration, and the artificial intelligence helps with this data verification or data validation before it actually then goes into the analysis. And again, the analysis also being supported with these tools, digital tools. So I hope this does justice to some extent to this very comprehensive answer that you have given. I'm just looking at the clock, so I think we want to closely come to an end, but let's just look again at our poll, because we had another poll which is about the following question. Do you think that the benefits prevail over the challenges of digital innovations for health systems, or is it vice versa? And very interesting examples. I don't know whether you can see it on the platform. So we had 71% saying that the benefits prevail over the challenges. And now some change as people are coming in. So it's changing a little bit. So yeah, make your votes, maybe just for the next few seconds. Okay, but we still have the majority of participants, seeing the benefits prevailing, and then 13% for both challenges prevail over benefits, so some skepticism, and then another group, 17% now as it's moving. This is like real-time data. They see the benefits and the challenges equally prevailing. So I find that very interesting. I would have put myself also into this category, that they, equally prevail, at least for health financing, I should say, as we still need to have more evidence on what the benefits are and, what are the potential risks. I'm just going up again and looking at the first question. So still efficiency gains, cost savings are seen as the major gains. And in terms of the biggest challenge, we still have technical and regulatory capacity gaps as the main one. I know there have been many more interesting questions, and we haven't been able to actually cover them all, but maybe some of the speakers can also respond through the chat function. But let me try to actually wrap up. So I think we had really interesting, we got really interesting insights into the use and the usefulness of digital tools from a variety of different fields, different applications. Certainly from what I gather from the discussion forum, you are experiencing that as well. I think there's certainly still an incredible emergence of many new digital technologies being developed, being piloted, being tested, implemented in low and middle income countries. And so going beyond these 3 examples that we had here, plus the 2 overview presentations, so talking really about the whole field, I think it's probably fair to say that for some digital tools, they're well established, and their use is being proven. For others, there's still need to further develop and update them to address data protection issues. I think one participant actually commented on them. This is always a big issue. For others, for others, maybe there is still need to prove their contribution and benefits The ultimate question that I would raise here is really, what's the role of government? And how can governments promote and support the take-up of useful and effective digital tools? So I think there's also a funding question behind that. And who actually decides about, what to support? I would also add the question of the private sector. What is its role and responsibility? A lot of these digital technologies or tools are actually, promoted, developed by the private sector. So, what kind of partnerships can we imagine here to establish, to develop? And if I just go back on the final slide, I know we don't have it here. Maybe I'll just wrap up by saying, I think we need to certainly get more information of what's going on, what is happening, what are the benefits. And as you said, if I just go back to the poll, implementation hurdles have been seen as an issue, but not primarily. Still, I think we need to ask the question, so how can they be made, how can they work? How can they be made working at country level? What do we need to know more about? What are the future research areas? I think there are many questions, broad questions in terms of equity, in terms of ethical issues, in terms of legal issues, but then also very specific technical questions. And with that, I would like to come to an end. It's a huge area, a huge field, so very difficult to actually deal with that in 1 hour and 15 minutes, but I think we have digged a little bit into that. Thank you so much for your participation. Thanks for the great questions, and we will take note of what's still there as we continue the discussion. Thank you so much. And of course, let me thank you very much again, the speakers, for their great presentations and for this really good exchange. Thank you. Thank you to all.